this, we will continue our meeting with Mr. Yvon.Riendeau. Mr. Yvon.Riendeau, who I met by happenstance 30 years ago, and he said, "Oh, you were there," and who is... This is the beauty of what we're doing today, is that all sorts of people, for several years, we've been working parallel to each other.
We will now allow Yvon, he's not a lawyer, I said Maître Yvon, but he is a master in his own right. So he started as an orderly, and he started looking at different problems that he saw in his career, and then he became a gerontologist, sexologist, consultant. He's a professional troublemaker, but he's a good kind of troublemaker, so that things change. So he will be up here momentarily. He was one of the signatories for the first government policy on abuse in institutional care with Marie Beaulieu and a few other people, if I remember correctly. So I will now let him speak to you. I don't know if you remember, in 2000-2001, the Commission on Human Rights had done a public consultation with 110 memoirs. So at that time, we were talking about creating a safety net that would help people in vulnerable situations. Monsieur Yvon.
Alors, merci. Je vais
Thank you. I will use the microphone. I'm just going to create a little bit of space here and use my mortal weapon, which is time. So 30 minutes is 30 60-second turns around the clock. So it's going to go quick. So that'll bring us to 10 with a bit of tolerance, 10-15 max. Good morning, everybody. I hope you're having a wonderful day. I hope this day has been great for you so far, and we hope this brief presentation from me will give you a bit of history, a bit of color. So mine will start around 2003, if you will, with the ministerial orientations around quality of life. So this was a title that was asked of me, the realities and challenges in CHSLDs, and so there are long-term care facilities. That's part of their reality, having done work to implement and fighting against mistreatment and favorizing quality of life, but it's also still a challenge in some cases. So there's still there are some improvements that have been made. We still have some work to do. We've evaluated the implementation processes to favorize well-being. So the authors that I spoke with also will agree on certain of these parameters, but there's still some work to be done, and it's one of the reasons I imagine why we are presenting this today, talking about challenges and realities from 2018 on. So thank you for the invitation. Thank you for the introduction. François Legault, if you remember, he was a Minister of Health in the PQ in the early 2000s, and he had this innovative idea to start with a concept called the life environment concept, the living environment concept. We, Carpe Diem and other consultants, as well as with me, we were called on to talk about this and to explore this. So I was from the health department. It started there, and it progressed, and so I had the privilege and the honor of helping managers and employees to navigate through this, through 115, 120 different long-term care facilities in Quebec, and from Île-de-la-Madeleine to Ottawa, to help them train the personnel with this new concept. So starting there, and we see today, and I will come back on the Couturier's work in Aubray, among others, that there's 63% of the long-term healthcare facilities, private, permitted, government, public, were able to make advances in implementing this process to improve quality of life. So in other cases, it was a partial effort and partial success, but there's still some challenges in some organizations. So I don't want the presentation to be too macroscopic, too global. We don't want to lose the forest for the trees, but we want to start with generalities and get into specifics near the end of the presentation concerning challenges going forward. So This action plan for quality of life against mistreatment, there's 148 elements that were put forward to the government of Quebec. 148 to give you a first document, probably in the room here. Everybody knows this document, this one here, government action plan to fight against mistreatment. The second one, as Madame Beaulieu said, was put into action in the last years. So that said, it is within this window today that we're looking at all of this. So it's an important time out that is within the limits of the Handicap-Vie-Dignité and what we're doing. So there are also many challenges and realities. It's the title of my presentation that are on the agenda. So first of all, I will talk about a few elements, very global, micro, have the best working environment possible. It's a reality, again, in certain spheres of activity, so in the realities that are in place and how the personnel gets along and who works there and the personnel. There are some sometimes there's some great environments where everybody gets along well, and other places where there's a lot of conflict. So we have to take action to work on people's attitudes and the way they deal with each other, whether they be nurses, ergotherapists, physiotherapists, orderlies. We can talk about all of those, but it's a challenge to be able to have best practices and different kinds of clientele, those who are losing autonomy, those who are vulnerable, those who are gaining their autonomy back. So there has to be a systematic taking charge, and there's an important challenge there in terms of day-to-day how we do things. So the third little point here is having a better attitude. It's a word we hear often in healthcare in terms of work ethic, professional behavior, rigor, discipline, self-regulation, metacognition. All these elements are the order of the day in terms of academic training, but also continuous training throughout the careers of these persons. So the attitude towards residents, towards families. Today we have an important adage today. We talk more and more about residents and close family, residents and close families. So it's like we have a larger systemic vision of the different stakeholders and actors that are around the residents. And also talking about a life environment versus a working environment. So I'm saying this again for people who forget. The living environment of the residents is also the working environment of the people who work there. So we can't dissociate those. You are working in a living environment. You're working in somebody's home. So the 15th anniversary today of this concept, but this living environment and working environment, this marriage of them, the visitors and the employees and the volunteers as well must be included in the analysis, macroscopic and microscopic as well. So the frame of reference that we're working under right now that is still de rigueur is the AMV one, the living environment approach milieu de vie. Different orientations from the health department. All this is within a policy that is a much larger one of the respect of people's rights that are losing some autonomy. So Article 33 of the law of healthcare and social services, there are some fundamental elements there. The importance of espousing the mission. We all have a mission that is black and white on paper, and this mission has a few key words: safe services, effective services, laundry services, food services. All these quality of life services are just as important as care services. So all these services, we can talk about all the different details within each one of them, but we're not going to go into details. We only have 30 minutes. It's not the objective of this presentation anyway, but the important distinction here is when I had the privilege of doing a memoir on this, the quality of care in long-term healthcare facilities, and by extension, putting forward the feasibility of the implementation of this of the quality of life concept. It took me 17 pages to write that, to define the word quality, because it's a very polymath kind of word. Quality means a lot of things for different people, different things for administrators, different things for the directors, for the visitors, for the residents. So the quality of service, quality of food, quality of the air you breathe, quality of the furniture, quality of all kinds of things. So it depends on who you speak with. So quality of a living environment concept, the quality of life concept relative to the environment. So I'm still relatively new to training personnel in this, but living environment, we talk about environment, that really wrecked our mission. It came in this concept and these words, and this concept was brought in. Some people think it was brought in haphazardly, but as I want to say that it wasn't really interpreted in the right way by certain people. So starting from there, this living environment, the Burgundy words seem important to me. I hope you share that. A warm, welcoming, safe, secure place where they are taken charge of and they are taken care of, and they're there for less and less long. We are changing the name because it's not as much long-term care. It's more medium care and short-term care now. So things are moving a little bit now. Things move quicker. When I started in Drummondville as an orderly, it's a different clientele than what we see right now. So these physical health profiles, cognitive is also there. It's important to have an environment that will adapt. In terms of food, I won't get into dysphagia, different deglutition reflexes and all that. We're not going to get into that now. But this notion of the situation of equality in terms of food, in terms of everything around the clientele that has cognitive deficiencies. So we've adapted the activities, we've adapted the food, all that. Monsieur Riendeau, we're bringing residents to the lift, and when they get to the first floor where there are the activities, we take them downstairs towards the environment where they can have some activities. That's where the environment is. We understood here that the concept was not integrated correctly, where there's a separation from where they sleep to where they enjoy themselves to where they a living environment, and a milieu de vie in French. So there's international standard organization, ISO SMAF. It's a system for measuring functional autonomy, SFMA in English. So we're talking about 10 to 14 physical and cognitive deficit, pretty heavy. So we're talking about 80% of the clientele in long-term care that present deficits, cognitive from medium to severe, that changes the map and the composition of the clientele, and also changes the practices, changes our approach. It changes the parameters of the environment. So also we have a vision that accommodates the mission that we espouse and the personnel that is mobilized and that is invested with a clientele that is very specialized. And so our vision is to maintain or increase the reputation, the expertise of each of these long-term healthcare facilities. So that's part of the challenge. So as you can see here, I hope you can see the screen clearly from the back. The question of quality also is a difficult one to define in a pure way, to crystallize. So there's an element here that is important to underline. We hope and the managers and the personnel and the volunteers are engaged and not enraged. There's just one letter of difference, but we want them engaged and not enraged. So incompetent, dynamic, etc. So in these this first part of the presentation was to go over the essential parts of our mission pursuant to Article 83 of the law, and this vision that we have to oil the wheels, we have to oil the cogs, and we have to feed the machine. So it's a reality in certain of the environments and a challenge in others. So this is a slide I've been carrying for 15 years. It seems very significant now. I'll present it in 1 minute. So milieu de vie orientation, quality of life orientation 2003 to 2018. We have the visits to define or evaluate quality. I don't know if you see that, but the visits to evaluate quality, I'm not going to say it's armies of people that came to audit or evaluate, but sometimes haphazardly, sometimes randomly. There were some good successes as well as some issues. But this concept of a living environment, a environment of quality, all these challenges that could be interpreted or installed in the launching of this concept of the quality environment or a quality of life environment. So this we see here this in this bubble that's very important. I'll take the time to pick through it. I don't want to get into extreme detail, but the reorganization of things. So that is very important. So very humbly and with respect, reorganizing the 24-hour clock was the first element where we had to look at the hours where we gave care and spread them out differently. Those who know the long-term care facilities know that in the morning we say the plugs, these plugs can introduce not only some friction but some individual abuse that we call systemic mistreatment. So this reorganization of the 24-hour clock, some were able to do it, others were not able to do it as well. Food in bulk, we've got self-serve food in a lot of places. In other places, it was cafeteria style. So some places served coffee and toast personally to the residents in the morning. Others were more depersonalized, so less personal, and so it's a social interaction that replicates the breakfast at home, the home life. So there's also the different leisure activities in the different units. So I'm just going to talk to you about this is just the orientations of the government. So these have some leisurely activities with the personnel. So to have activities together, so that the meals will be an activity and leisure activities are also with the personnel in collaboration with them. So it may make you smile. You may think of what you know of the healthcare system now or where you work. This may be part of your reality, or maybe it's just a pie in the sky wish or a challenge. So another thing is the adapted environment, evolutive environment that is in evolution. Do you have things that you don't need, maybe that can help? The principle of maybe an old phone that an older person would like, or accessories that people have brought to make the environment more comfortable. So it's a collaboration with the personnel, and they have adapted the decor. They've changed some things for not a lot of money. So the orientation says, look around in your environment, adapt your environment, evolve it to these people's home life, make them feel more welcome. And for others, some applied this very well and others did not. So this concept here, this other orientation, was also in interpersonal relationships between the personnel, between the different departments. The collaboration are across the 24-hour clock. So you see here these three little bubbles, or these three little boxes, contain a lot of things that needed to be worked on, and some people have followed these and others have not. There were some challenges, some recommendations to, that's what they say in this guide here, recommendations that they issued to be able to achieve these fundamental elements. This committee also that is struck around the quality of life environment that was very strong for a few years in certain places, and some have dropped it, and some have continued to work on it on a lesser level. But visits and audits with recommendations that we've seen in the past, that still happens today, I believe, and so that some areas have advanced quite well, and the personnel in general was very excited or criticize the feasibility of these things. So sometimes at the same time. So this notion of adapting the 24-hour clock for the residents, we were saying earlier that the clientele has changed, the profile has changed, and in terms of autonomy and the complexity, we say it's a more complex composition of the different users of the system. So some people will like what I'm going to say, some people will not, but it is to look at the time of the day or the evening or the nighttime or the morning to give some basic care to certain residents at different times that was a bit like a parent with a newborn baby that would not sleep through the night and wake up at 4 in the morning to give care. So we should look at it like that in a certain way. So to demedicalize and give it a non-institutional kind of feel, to give it a more home kind of feel for the residents, more comfortable and warm and comfortable for the residents also who work there. So 80% more or less in Montérégie. We have 77 or so centers. So provincially we're in the 80s. I don't follow that every day, but that said, we it's more than 50, but more than 75. So we are in a ratio where the personnel and the managers have to compose with a clientele that has increased. So the interpersonal relationships and the working relationships is a challenge. Sometimes the working environment is not that pleasant. There's also some questions of ethics and meetings between the personnel to re-examine this, to have meetings. I'm going to talk about Kaizen later on, constant and never-ending improvement. This never-ending search for best practices. So these are things that we have put in. It's called a toolbox, and it is so that the people working there can implement these things. So what's important for me to take away from all this is that we've made a lot of efforts in certain cases. In other cases, it's not about political partisanship, but later on, in some cases, there was a clientele that was much later in arriving in long-term care. So it's a bit jeopardized the project, this living environment, this environment of quality of life. I'm just going to show you some images. Cohabitation in terms of residence is a reality that is interesting to examine for the reasons we all know. It's a forced cohabitation. None of the residents choose the other residents in their unit, or sometimes even in shared rooms. So these are people who sometimes are used to living a certain way at their own in their own apartment, their own home. They have their own ways of doing things, their own habits, and when they have to cohabitate or room with somebody else, there's territorial issues. Sometimes it can escalate towards aggressive behavior, and sometimes it is important to have optimal relationship approaches and to encourage optimal relationships. So we're talking about a vocation. There has to be a vocation to work in this. So in this field. So we need special people, as you well know, people who are involved in all of this. You need people who are very patient, very strong emotionally to work in this context with a very specific clientele. So the key words here in green is the realities we hear sometimes when I work with the personnel. So I talk to them. I try to see what they feel. They feel tired. They feel powerless. Sometimes they feel that they're watched. They feel that they can't do what they need to do all the time. They don't always have the tools, but that introduces some relationships sometimes into the environment that are difficult. Some people have difficulties in working with certain other people, depending. It doesn't really depend on the job or the seniority. It's really sometimes people just don't work well together. So it introduces a reality into this reality that we know about within the employees. So they collect there are different groups for the orderlies and for the nurses. There are committees where there's less. They have to work on pressure, under pressure, and also they have to always perform. There's this concept of an assembly line, this Toyota assembly line, this 5, 10, 15, this Kaizen concept. So we're looking for things to get to the best quality possible in the present context with the clientele we have.
And the employees that we've got as well. So obviously, we're always going to have chemistry with the staff. We always want to be in a reality where the challenges, where the employees can work well together, and we'll always ask ourselves fundamental questions. Does the staff, regardless of their jobs, do they have access or accessibility to continuous learning and to discussions? You know that there are some European models that were borrowed here in Quebec, the Kaizen table, where we look at the good things, the successes. So in the work culture, in the organizational culture, are we regularly highlighting what's done well, or do we only highlight what is not going well? So for the group dynamic, the work dynamic, we've got in our challenges or in our realities, we've introduced these mini meetings, 5 minutes, 5 minutes, 10 minutes, 15 minutes per day, to talk about the day and to name the things that went well. Once again, it may sound a little bit funny for some people, but it might seem like a good project for other people, right? So obviously, we have to ask ourselves some questions as to the program while respecting the global rights. We have to ask ourselves about, well, you know, it's a bit cliche, but we have to talk about the flexibility of the personnel. Sometimes the staff is a little bit like caught in a sandwich between the decisions and the implementation of the decisions, the administrative decisions, according to the budgets or the work culture and the managers in place. Obviously, once again, we are going into basic parameters as to the work ethic. So to keep a morale, talk to teachers or all sorts of jobs in Quebec where we must do everything possible to keep our morale up with the realities of today's workplace. Well, that's a case for us as well, to take some time to do the tasks. I put it in orange because the notion of time, I've been hearing this. I've been doing training for 32 years in this field, and I hear it every meeting. Mr. Riendeau, we don't have time. We don't have time. We don't have enough time. I'm not gonna. Oh, I've got 10:05 on my watch here, so I'm going to follow my watch. So there's the organizational that is important, also the relational aspect as well. So the two become important. I hope that even if I'm speaking quickly, I hope that the main message is well understood, because at the risk of saying something that you won't like, but the punitive aspect in the PAB, we'll have an opportunity to talk about this during the panel. We have to keep an eye on that because it's become so we're blaming everything on this. So there's a reality, some realities. So adapted communications that adapted to the residents who may have a cognitive decline. So there's this effort to adapt. And in the schools, whether it's at DP or schools or universities, colleges, we put the emphasis on adapted communications that are adapted to the clientele, which is lucid or which is confused, or who have Alzheimer's or some other kind of cognitive decline. There's also the notion of moving about, the installations, all the details, the day-to-day details, which must be examined in a precise way. So when we talk about a living environment, we're talking about the unit head, and not necessarily the managers, but the staff who work there. Another thing that's important as well, it might be a bit of a cliche, but I think that we have to share it this morning. We have to take the clientele as it is, with what they're going through, despite their overall health, despite their personality. And it's not up to us in our offices, in the universities or the colleges. We're not the ones who are in the field. It is the actors in the field with the clientele that they're working with the realities, the life realities and the work realities and the conflicts or the nice environments in which they work. Between you and myself, is it always going well? Is it always easy to work with the clientele and certain specific colleagues? The answer is no. That's why it's important to go get an energy, an internal energy that is positive, so that we can work in the best work environment possible. So the living environment is the workplace for the staff. Now from this notion of honesty, of loyalty, with what, and I'll go in detail here, it's this one. What do we have to have? So I will, we have to target the work atmosphere. Obviously that's a plus, and the qualitative work environment, an optimal work environment as well. We have to talk about this. And we have to get to one that's less important, which is the suffering of the personnel at work. And by the way, I'm not pleading for the employees, but it's just a fact. We have to look at solutions in 5, 10, 15 minutes and to work and foster a vision with a quality work culture with participative management, which we call from the bottom top and top to the bottom. Often it's top to bottom. The decisions come from the top. We apply them in the field, whereas there's participative management that could also add to this culture the impression that we are participating in the decision-making process, in the undertaking of the rights of the clientele. In this last column, to have a partnership with the resident committees. I've met many of these committees, and sometimes there's a power struggle. There are some ideas that take shape. There's all sorts of realities where the committees are also in conflict or have specific contacts. They've got the mandate of recommending things. So this is an element we have to work on. The recognition of the staff. Very few installations have these types of processes in place. So obviously, this could help motivate. Now, a charter on well-being, we're going towards this type of element more and more. And once again, the manuals, the orientation manuals for residents, some are very explicit, some should be reworked. Now, the respect of the decisional autonomy, Mrs. Beaulieu talked about this. She talked about empowerment and her feasibility. Now, the leadership with the nurses. It's not nursing police, but it's a leadership. One element, one basic element, which in certain cases was implemented, and in other places it's still a challenge. We have to, in conclusion, have a commissioner of quality, a person who will have an objectivity and clarity when it comes to the consultants in the living environment and the accountability of the managers when it comes to quality. So we should have practices that are 24 hours a day in a context that we understand, that is integrated, and that is fostered. Indicators of continuous quality from Agrément Canada are also a motor to revise our practices and to look for continuous improvement. And once again, perhaps even in certain environments, that's where we are as well, we have to review perhaps the attitude. We talked about this, but the vocabulary, the use of cell phones at work. I'm not going to comment on these things this morning, but there's still some work that needs to be done there. And in the reality, so improve consent and the abolition of evacuation in the bed, which is normalized in certain places for all sorts of reasons, to foster assistance measures when it comes to personnel that is inadequate. So either a measure, program to help employees or disciplinary measures. I don't think that's the thing that you should remember, but it's something in leadership, in nursing leadership, that we have to put back on the table. The best admissions possible of new residents, of colleagues and other people who are in these living environments, and a sound use of the contentions that are authorized in 2018 version to foster the death of the theory of blaming. Perhaps this is something that should be a challenge because the presentation was realities and challenges. And this is my last slide. We have a legal framework, as was said earlier, and in a legal framework with a code of ethics, without the conclusion being a vector for this, but with a code of ethics. So obviously the code of ethics under Article 233 of the Act are important. Leadership, the nursing leadership, I put it in blue and I wrote leadership plus because I've done a lot of training with nurses. There are some who have leadership, and for others it's harder protocols in the workplace, not just written protocols, not just distributed, but you see underlined here, applied. A collective of employees, of families, of managers, according to the McGill approach, who have to work together, obviously, in the same type of undertaking of the whole of the daily activities. Coaching meetings, once again, some environments are doing this, in other environments not so much. We say starting tomorrow. So it's 10:10. That's all the time I have, so thank you for your attention.
Merci, Monsieur Riendeau.
Thank you, Mr. Riendeau. We'll leave you a few moments to have some water. So it's question period now. Mr. Riendeau is here to answer your questions. There are microphones throughout the room. There are some people who are here from Vanier College who will... You just have to raise your hand and they will come see you with a microphone. All right, we've got a question over here. We've got 10 minutes for questions here. On one of your slides, you made a link between living environment and care environment. With the complexity of the clientele that we see in the nursing homes now, we know that I read that we're towards 12 and 14. So the balance between the two concepts, is it moving? Is it moving more towards the care environment and less the living environment, in your opinion? That's an excellent question. It's a question that's a hot topic right now, and my answer is, there are experts in the room who could take the microphone at any time, but I'm going to tell you in 2 minutes. When we started with the idea of the living environment under Mr. Legault, he was the one who really gave the go. When we went to the field, there was the approach with Mrs. Ronan, there was the Carpe Diem approach, which gravitated around this, and I think that we inspired ourselves. We took some inspiration from all of this, but it was very exciting from 2003, 2011, 2010, and then we had the new parameters of access to these institutions and the clientele. Without going into technical details, so it's as if the wind has changed. This is a personal opinion. The wind seems to have changed towards an uptake in a context of a care environment to the detriment of the progress that we had made with the living environment. So I think that the cohabitation of these two, care environment and living environment, it's something that for the time being, I would say that is succeeded and failed. And in the Couturier work, actually Couturier and Aubry work, there's some progress being made where we say that certain people manage to respect the minister's guidelines. So it's a gray zone. But I would have a tendency to say that you are correct. We had somebody on the other side who had a question. We're going to go to this side. I saw a hand in the air. Over here. Okay, over here. I'm sorry, we've got the lights. We can't see well. We can't see. Is the microphone there? You've got the microphone? You've got the microphone? Okay. Is this working? You talked about a lack of time for the orderlies. I have seen this. My mother's been in a nursing home for 8 years. I would visit every night. I was not really somebody who was super... I would send letters in a very professional manner. I would complain about this. And in fact, it's not always a lack of time. There are some protocols. For example, I documented this. I took some pictures of my mother's face and nose and eyes. It were filthy. And my mother would have her breakfast. They didn't want to clean her nose. And when I did it myself, they didn't want to give her breakfast because the protocol, according to the orderly, was that the breakfast was taken before we clean the nose, whereas you and I, we clean ourselves before doing this. You've got a good case. What is your question? For the ministry visits, what was done so as to not ask the government to plan this in advance and perhaps be there when they're giving meals to see these types of things and come at night and on the weekend when the bins of diapers are there and quickly, time me 1 minute. I'm going to start with the end of your question. At the beginning, the appreciation visits were announced. They were announced perhaps 1, 2, 3 days in advance. And towards the end, the visits were just done like this without being announced. Secondly, we have to remember one thing. I'm going to go back to what we said earlier, the 3 bubbles, the organization of the work, the organization of the 24-hour cycle with the care protocols from one establishment to the next are not totally applied in the same way. So when it comes to the organization and the protocols, firstly. Secondly, we have to remember that there is, how would I say this? The real people who offer the services, regardless of the type of job, okay, we're not just going to talk about the orderlies. They all have their way of seeing their work. And we are not in agreement or in agreement. But this said, depending on what we see and hear, so it's interesting as a question, but there's not one answer. That's why I'm talking about the 5, 10, 15 minutes. That's why we need leadership on the nurses' part. That's why we need reminders on a daily basis of ethics, etc. So this is work that is extremely important. That's done in certain environments, but I've seen it myself. In other environments, they're excited to say, okay, we're going to do these things. We're going to meet the challenges. We're going to make it a reality. 6 months later, it falls to the wayside. So the follow-up is difficult to do. 2 minutes is difficult. Is there another question? We didn't go on this side of the room. Is there another question? Over here. I want to ask you, the clients who work, the employees that work with the patients, what resources are available so that people know their rights through access to information? Because often there's not enough resources on that side to empower the individuals who are abused. Mr. Riendeau tells us that this question, when it comes to the rights, will be discussed this afternoon in a workshop, so you'll get an answer to your question. We've got one last question on this side, and afterwards we'll go to break. The microphone is yours. Hello, it's to answer the previous question. I'm Manon Fortin. I'm General Director of the Fédération des Centres d'Assistance et d'Accompagnement aux Plaintes du Québec, so a complaint board. You've got one center of assistance for complaints in each one of the regions of Quebec. They are community organizations that have been around for 25 years and which can help you, inform you on your rights, and accompany you if you want to lodge a complaint. And that is linked with the Commissioner to the complaints that Mr. Riendeau mentioned earlier. These services are free, confidential, and even the consultants can even come and see you. They can go to the actual living environment, and we foster empowerment. That is, we help the person, we help them to write their complaint, we inform them of their rights, we are present with them if they meet the commissioner, the complaints commissioner, and this is for medical complaints as well. And there is a second recourse as well when it comes to the citizens protection or the revision committee with the medical complaints. So we work in collaboration with the user committees in the establishment. So just to tell you, one number to remember, 1-877 767 2227, and the 2227, and the consultants are professional consultants, and when you call that number, you will automatically be in your region. You will speak to somebody from your region, and they're all wonderful people. Thank you. Thank you very much for this answer. And this afternoon, we said that this morning perhaps it would be a bit more theoretical. This afternoon, it's really going to be workshops. We're going to give you tips. In these workshops, you will get more information. So thank you very much, Mr. Riendeau. This was very interesting, and we will see you a little bit later on.